The CLEAR Outcomes trial was a fascinating trial that actually headlined the ACC, the American College of Cardiology Scientific Sessions World Congress of Cardiology. So it was, I would say, probably the trial that everyone was most excited about seeing the results of. And it was a Saturday morning, first late breaking clinical trial. And this was almost 14,000 patients who were statin intolerant. So extremely unique population that has never before been studied in a cardiovascular outcomes trial. And statin intolerant meant that you could either not take a statin at all or just tolerate a very low dose of a statin, and escalation of dose led to muscle side effects or what have you. And then it actually added both primary prevention, so patients who were at high risk for cardiovascular events, and secondary prevention. What was very interesting about the trial was a high percentage of females, 48% females, again, unprecedented in the cardiovascular outcomes literature. And then, of course, the baseline LDL of the patients in the trial was 139. So for high-risk primary prevention or secondary prevention, a very high baseline LDL. And it looked for major adverse cardiovascular events, and we had a positive trial. So it reduced LDL by about 22%, reduced high sensitivity CRP by about 22%, and the 4-point MACE was reduced by 13%, and the 3-point MACE reduced by 15%. Now, most of that reduction was driven by reductions in myocardial infarction and coronary revascularization. We did not see a mortality benefit, but a positive outcomes trial for a very difficult to treat patient population. Yeah, this was a fascinating trial for a number of reasons. One, because it studied unique patient populations, which I think was a huge strength of the trial. So, 48% women is something we really, really ought to strive for in all of our cardiology trials, is that equal representation of women. It studied, of course, the statin intolerant population, which is not a population that has ever been studied before in a cardiovascular outcomes trial with respect to prevention. And then, of course, it studied a mix of both primary prevention that was high risk and secondary prevention as well. So I think that the population in the trial was extremely unique and really, really filled a niche in cardiovascular disease prevention. Now, in terms of weaknesses, there have been some questions. Of course, the LDL lowering effect was only about 22%, which is something, but it's not extremely potent. So whether or not this drug is going to be used, bempedoic acid, as monotherapy by itself, or whether it's more likely to be used in combination therapy with ezetimibe, where you see an LDL lowering effect of 38%, is one of the questions that I have as a clinician. Personally, I think I'm going to use the combination therapy much more than the monotherapy, just given the degree of LDL reduction. And piggybacking off of that, one of the other criticisms of the trial was that the on-treatment LDL of these high-risk patients after treatment was only about 107. And we know from the expert consensus decision pathways that we really want to try to get that LDL down as low as possible, definitely below 70, but perhaps even below 55. So again, really begging the question of whether or not we should be using that monotherapy by itself, or really that combination therapy is what has a role in clinical medicine. The CLEAR Outcomes trial has opened the path for us to use a novel agent, bempedoic acid, which works in the same pathway as statins, but doesn't get activated in the muscle. So it doesn't lead to those muscle side effects that statins do. It's now got positive outcomes. So I certainly am going to start reaching for the combination of bempedoic acid and ezetimibe in my patients that are either completely statin intolerant, or it's an agent that I would reach for next if they're not quite at their LDL goal and I need to get them there, because it's an oral once-a-day agent, well tolerated, easy to use. There's no dose titration. So really a helpful way to get patients to their goal. And then a side benefit is that it doesn't raise your hemoglobin A1C like statins do. It reduces your CRP just like statins do. So it's having many of the same positive effects of statins without many of the side effects that we see with statins. So a nice tool in our armamentarium as preventive cardiologists.